we're talking about infectious diseases, and these are diseases that are caused by bacteria, viruses, and fungus. So, microorganisms are divided based on two things. Either they cause disease or they don't cause disease. This is known as pathogenic, which are disease-causing microorganisms, and non-pathogenic, which are non-disease-causing microorganisms. So the mouth may be the primary site of involvement for an infectious disease. And also systemic infections can also show up in the mouth as well. There are different ways to transfer an infection. It can be transferred through the air on dust particles or water droplets. It can be transferred by hands or touching objects. And sometimes the disease requires direct contact. So microorganisms, when they invade the mouth, they can cause a local infection, or they can cause a whole body systemic infection, or both at the same time. Microorganisms in the bloodstream can cause lesions in the oral cavity, and microorganisms causing infection in the lung can be transferred to oral tissue as it's coughed up and present in saliva. So basically the head and the body are all connected. So what is an opportunistic infection? An opportunistic infection is when an organism that is usually non-disease causing or non-pathogenic causes a disease. This can happen because the host's immune system is not as strong or immunocompromised, but the oral flora may be affected by changes in salivary flow, antibiotics, or the immune system. These are all things that can cause someone to have an opportunistic infection. Microorganisms stimulate the inflammatory response, and they also stimulate the immune system. What type of immunity is effective in defense against some microorganisms? Humoral immunity. Well, we remember that B plasma cells specifically, create antibodies, and so they are the ones that help defend against microorganisms. So the humoral immunity can defend against some of these disease-causing organisms. So, infections. We have 3 different types: bacterial, viral, and fungal. Bacterial infections. So these are going to be all bacterial infections: impetigo, tonsillitis, tuberculosis, actinomycosis, syphilis, acute and chronic osteomyelitis. So impetigo, or impetigo. This is a bacterial skin infection. It's caused by one of the strands of strep. It most commonly involves the skin of the face or the hands and feet. It's usually in young kids and requires non-intact skin for infection. So you have to have a cut in your skin or some sort of opening for the bacteria to enter for you to be infected. The lesions that you would see are either vesicles or bullous, which means they're filled with fluid. They can be itchy, and they can also cause swollen lymph nodes to occur. The bacteria may be identified by using a culture of the lesion, and to fix this, you just give topical or systemic antibiotics. So basically, impetigo, a summary, is it's an bacterial infection in kids causing blisters that are vesicles or bullous lesions. So again, impetigo. It's a bacterial infection in kids with blisters and bullous on the mouth and extremities. Tonsillitis and pharyngitis. This is pretty easy and self-explanatory, but tonsillitis is inflammation of the tonsils, and pharyngitis is inflammation of the pharynx. These can occur due to many different organisms, but they usually show the same signs: sore throat, fever, tonsillar hyperplasia, and erythema or redness of the oral pharyngeal mucosa, and they can spread by contact with infectious nasal or oral secretions. So how do you take care of tonsillitis and pharyngitis? You need to take a lab test to confirm if it's strep or not. And basically, if it is strep, it's important to be aware of that because group A beta hemolytic strep is related to scarlet fever and rheumatic fever, which are can lead to some more serious issues. So tonsillitis and pharyngitis, inflammation of the tonsils, inflammation of the pharynx, redness and white spots on the back of the throat. You need to take a lab test to confirm it's not strep. Why do we care if it's strep? Because strep can lead to scarlet fever and rheumatic fever. Okay, scarlet fever usually occurs in children. It's a fever and generalized red skin rash. In the mouth, it shows up in addition to tonsillitis and pharyngitis, and it also can have petechiae on the soft palate and a strawberry tongue. We say a strawberry tongue because it looks like strawberries when the fungiform papillae are inflamed. So that is scarlet fever. Rheumatic fever. Rheumatic fever is a childhood disease that, again, follows that same strand of strep. This one, though, causes inflammation in the heart, joints, and central nervous system. The heart valve damage may happen, and usually if someone has had rheumatic fever, we used to require them to be pre-medicated for dental visits, but now only if they regurgitate a lot and they're spitting up that bacteria a lot, they need to be pre-medicated. So do we pre-medicate for rheumatic fever? Only if there's regurgitation. Tuberculosis. Tuberculosis is caused by Mycobacterium tuberculosis. It is a disease involving bacteria in the lungs. Basically, the organisms are resistant to destruction of macrophages. The macrophages engulf the bacteria, and then, just like in Wreck-It Ralph, they multiply inside the macrophage and disseminate into the bloodstream. So tuberculosis, the biggest thing to remember is they are resistant to the destruction of macrophages. You'll see fever, chills, sickness, weight loss. In the mouth, tuberculosis is painful, non-healing, slowly enlarging ulcers. And this is due to spitting up fluid into the mouth from the lungs. And again, remember, tuberculosis is bacterial infection in the lungs, I believe, right? Yes, so when you spit it up or regurgitate from the lungs, that's how you transfer it to the oral cavity. How do you know if you have tuberculosis? You take a TB skin test. The antigen is injected into the skin, the purified protein derivative, and then if you have a positive reaction, you'll have inflammation on the skin. And also, people can take chest x-rays to see if the active disease is still present. The problem with tuberculosis is that more and more cases are becoming resistant to the drug regimens that they're asked of. They're not taking their drugs correctly, and the bacteria is becoming stronger and more resistant. And TB has been related to HIV infection. It can be transmitted from patient to clinician in dentistry, so you need to have standard precautions to prevent transmission. If patient has active tuberculosis, it's always safe to defer the patient. How is it transmitted to the clinician? Well, if you have a patient with TB and you're using your ultrasonic, that bacteria that's being spewed out from their lungs into their mouth can become airborne. So again, this is what it looks like in the mouth. Just have kind of a whiteness on the tongue. The ulcers and the lesions look like this, because remember, it's enlarged lesions. That's how it appears in the mouth. Okay, and now we have actinomycosis. This is caused by Actinomyces israeli. Basically, actinomycosis has to do with normal bacteria in the body that becomes embedded in the bone and starts to drain as an abscess due to trauma. So basically, patients with extractions or some sort of abrasion of the mucosa, the good bacteria called Actinomyces turns into bad disease-causing bacteria. And this is treated with antibiotics because you want to kill the bad bacteria. But basically, you have an abscess that is formed and it drains from a sinus. So you'll see tiny bright yellow colonies appear in pus called sulfur granules. So how do you know if something is actinomycosis versus just a regular abscess? You see the colonies in tissue from the lesion, and you need lots of long-term high doses of antibiotics to kill it off. So this is a picture of a fistula on the outside of someone's face, and this is a picture of it on the inside. Okay, so now we have syphilis. Syphilis is from a spirochete, which is a corkscrewed bacteria. The bacteria is called Treponema pallidum. Syphilis is transmitted directly. Organisms die when exposed to air and changes in temperature. So how do people get syphilis then if you have to transfer it directly? Well, it's usually transferred through sexual contact, but can also be transferred by blood or from fetus to mom, or mom to fetus. Alright, so syphilis has many stages, and in the mouth you'll see different things. But basically, once you contract syphilis, within the 3 weeks that you contract it, you're in the primary stage. And the oral lesion that you'll see is a chancre. And then once you're in the secondary stage, the chancre will turn into a patch. And then the lesion goes away and you're in a latent period. And you can be latent for decades or years. And then usually you'll have a third period where you have a guma. So let's go over those in depth. So again, when you first contract syphilis, you're in the primary stage. So in the mouth, the primary stage, you'll see a chancre. This forms when the bacteria enters the body, like we talked about. It's highly infectious, and it heals spontaneously, and the disease enters a latent period. So there's a picture of a chancre. Okay, now secondary stage. After it's a chancre, it becomes a mucus patch. In the mouth, you'll see multiple painless grayish-white plaques covering ulcerated mucosa. These lesions are the most infectious. So, out of the 3 stages of syphilis, which lesion of the mouth is the most infectious? It's a mucus patch. They undergo spontaneous transmission, but may occur for months or years. So, it looks like a reddish-gray patchy part of the tongue. Okay, and then the last stage, like we talked about, you'll see a guma. This is when the lesion becomes firm, and in this stage it's not infectious. But a destructive lesion can result in perforation of the palatal bone, so you have to be careful. Typically, patients will begin to die from syphilis after many years because the bacteria can travel to the brain or the lungs. Okay, and then the other type of syphilis we talked about is when it can be transferred from mother to fetus. This is called congenital syphilis, and it can be serious and cause irreversible damage. What kind of damage? Well, the baby can be born with mulberry molars or Hutchinson's incisors in their baby teeth. So how do you treat or how do you diagnose syphilis? You need a blood test, and you treat it with penicillin. Alright, then we have acute and chronic osteomyelitis. These are the last of the bacterial infections. So, acute osteomyelitis. This means it's quick inflammation of the bone and bone marrow. It's usually the result of an abscess, a periapical abscess. But it can also be from a fracture of bone or from bacteremia. So how do you diagnose it? You need a culture. How do you treat it? You drain the area and give antibiotics. Chronic osteomyelitis. This is when the inflammation of the bone is there for a long time. The bone becomes painful and swollen. Radiographs reveal a diffuse and irregular radiolucency that can eventually become opaque. So why does that happen? Why does the radiolucency become opaque in osteomyelitis? Well, you lose bone from the inflammation, and the body starts to add bone in the areas. So when the body is adding extra bone, you'll see a denser area in the radiograph. Chronic osteomyelitis can also be known as chronic sclerosing osteomyelitis when you see the radiopacity on the x-rays. So there's a picture of it. You can see the little extra bone right there. And that's it for bacterial infections.